Good evening, everyone. I am Dr. Neha Singh, and on behalf of IP Raigar, I welcome all the respected dignitaries, senior colleagues, and all the attendees on the live YouTube channel. Friends, we all know that 2nd of April was World Autism Day, and the theme for this year is inclusion in the workplace. Today, IP Raigar, supporting the World Autism Week, has arranged a special program for the awareness and acceptance of autism in the society. I would like to invite our president, Dr. Pramod Wankhede sir, to say a few words. Welcome, sir.
Thank you, Neha. Thank you very much. And good evening to all. All respected Dr. Gangulia sir, President Maharashtra IP, Dr. Dabadkar sir, Senior Pediatrician, Dr. Chitra ma'am, our expert, Dr. Leena madam, Dr. Shilpa, all the dignitaries on the board, of the board, good evening to you all. And I extend my best wishes for this Autism Week. And on behalf of that, we have arranged this lecture to increase the awareness and for early pickup, so that the early treatment can be instituted. Friends, you know, autism, previously I heard that it is 1 in 500. Then few days or yesterday or day before yesterday, I heard that it is 1 in 68 and also coming down. So common this disease is, and if we are missing, it is injustice to our patient. So early pickup should be there. There are some features, for example, loss of no eye contact or not responding to name call, but that is not enough. That should be measured with a specific scale that is called M chart. It is given, you can download it, and there are very simple questions, and if you go through it, the patient can be very well screened accordingly. To increase the awareness of this, we have kept this expert's speech, Dr. Leena madam. She has got vast experience behind us, and let us take some more information regarding the disease. Thank you very much. Over to Neha.
Thank you, sir. I can acknowledge the presence of our Maha-IP President, Dr. Hemant Gangulia sir, Dr. Dabadkar sir, Dr. Chitra Kulkarni ma'am, and many dignitaries on the dais to give. Thank you for joining and giving your blessings. Today, friends, the topic for today's program is screen early, intervene appropriately, and accept socially. Speaker for today's program is our dear Dr. Leena Dehspande ma'am. Welcome, ma'am. While Dr. Shilpa Namyar will be moderating the program. Over to you, Dr. Shilpa.
Thank you, Neha ma'am. Good evening to all the respected seniors and colleagues. Our talk for today, as we know, is about autism and how we can pick it up early in OPD practice, and how we will be able to intervene appropriately and counsel the parents appropriately. So as Wankhede sir was saying, the prevalence of autism initially in 2010 was around 1 in 125, and by 2020 it has come down to 1 in 54. So as the increasing prevalence of autism spectrum disorder and post-lockdown, we as pediatricians also are seeing a lot of children with various behavioral problems. So it has become necessary to detect all the developmental conditions early so that we can start intervention early. So it is very important for us to be familiar with the screening of ASD and appropriate evaluation, how to counsel the parents for going to a appropriate expert. And to clear all our queries and difficulties in dealing with autism, we are privileged to have with us today our esteemed speaker, Dr. Leena Dehspande. Ma'am has worked in the UK for around 10 years after completing her MD Pediatrics. She is the founder of ICANN Child Development Center in Kharghar. Ma'am is the visiting consultant at Apollo Hospital, MGM Hospital, Navi Mumbai. Ma'am is the National Joint Coordinator for Trainers of Neurodevelopmental Disorders, Autism and Poor Scholastic Development. Ma'am is also an IAP task force member of National Consensus Guidelines on ASD, Autism, Newborn Hearing Screen, and Learning Disability. And she is an academic editor of IAP Handbook of Developmental and Pediatric Behavioral Pediatrics. And she has been a faculty on various forums and our dear teacher also.
Thank
Before we start ma'am's talk, I would quickly brush through the normal developmental milestones that we should be looking at when the child comes for a well baby visit or vaccination visit. So when we have to do a developmental surveillance for all the children, and it is best to link it with the time of their vaccination, as that is the time when the child is actually well and is brought to a pediatrician. It is recommended to do a newborn hearing screen for all the babies to detect any problem at the earliest so that rehabilitation can be started. Visual responses and hearing responses are to be checked at every visit with monitoring of growth and growth on the growth chart. A baby usually starts to fix an object by 1 month of age, and by 3 months, the baby is able to hold his neck properly and can fix and follow in circles. By 5 months of age, a baby can hold an object in his hand and can transfer it from one hand to other. The red flag signs for a 5-month-old baby would be not achieving head control, not keenly looking at the face of parents, not localizing to or turning to sounds, or having a microcephaly. All these can be indicators for risk of future developmental delay. When the child comes for a 9-month-old vaccination visit, what are the things that we should be looking at? Is the child sitting by himself? Has the child started babbling it? Does the child engage in social interaction by looking at the mother's face? We can show him a toy and hide it under a towel. We can see if the child is able to remove the toy and uncover the toy. It shows object permanence, has emerged or not. A small raisin or a sugar crystal can be given to or can be offered to the child to see the grip of the child if he is able to have a proper pincer grip. So red flag signs at 9 months of age would be the child not being able to sit yet, not turning to sounds, having a poor face regard, or having a tendency to stand on the toes or scissoring. When the child comes for the 18-month booster visit, we have to see if the child is walking well without support. Is he able to pick up a toy without us pointing or showing? Is he using words purposefully? When we ask a parent, is the child speaking any words? They usually say, Mama, Papa, bolta hai. But are those words directive for a purpose to get the parents' attention? It has to be meaningful words, meaning to specific person for a reason. Even domestic mimicry starts coming by this age. When we can ask about if the child looks at mother or father and copies what they are trying to do. So this means that the child is observant about the environment or people around him. A child by this age is usually able to point to 2 to 3 body parts when asked. If we show the child a revolving top, or a toy with a light, and when it stops, the child when we give it to them, the child usually looks at the toy, look at the mother for her response, and again at the toy, and to see if the mother is also looking at the toy. So this is what we call joint attention, and it is very important to develop by this age. And when the toy stops, the child usually gives it back to the mother or the pediatrician to ask him to do it again. So this is a good interaction that the child can be given, that the child can give. Even when the child is crying, you can always observe that the child looks at the mother with an anxious face to indicate that he is not comfortable. So red flags at this stage would be not having an intent to communicate, not seeking for help, not waving or pointing, poor response to name call, and poor eye contact. He tends to communicate only by crying or pulling people, or when he is seeking for help, he is not able to point or give a good eye contact as a red flag. When the child comes for a 2-year-old, 2 years of age for a visit, he has to be able to interact in 2-word phrases. But these words should not be learned words or rhymes. Child should be able to indicate for its needs well, run, pull down his pants, help dress by self, and if child is given a pen and a paper, we can observe the grip in which the child is holding the pen. Red flags at the age of 2 years would be not able to verbally indicate for needs, not pointing for objects of need, and not having any pretend play. At 18 and 24 months, we should also be screening for ASD. And to elaborate about ASD, we have and how do we approach a child with autism? I request Dr. Leena Dehspande ma'am to unmute and share her presentation. Over to you, ma'am.
Okay, thank you, Dr. Shilpa, Dr. Neha, Dr. Pramod. It's a good evening all. It's a pleasure to be here. I thank IIP Raigad for this session. I've been told to, let me start by sharing my screen first. So I've been told to talk about what a pediatrician can do in their daily practice. Can you see?
Yes, ma'am.
Okay. All right. So what a pediatrician can do in their daily practice, and what I'm trying to do is, can you see me?
No, madam.
Yes, ma'am.
Only PPT can, we can.
Don't be saying that it's crashed.
No, ma'am. We can see your presentation also, and you also.
Just give me a minute. Just give me a minute. 1 minute. Huh? Little bit of thing from my side. I'm going to, can I just log out and log in again?
Yes, sure, ma'am.
Sorry about the problem with the Zoom. Okay, so what I'm going to do is I'm going to try and focus on some things which we can start doing from, say, tomorrow, early morning tomorrow. You go in your OPD and there is a child with a suspected ASD or a child with autism who's come back to you. You should be able to know what is to be done in the OPD. Now, recently, the prevalence of ASD has increased so much, as all of you have said, that the first case which I'm going to talk about is going to be a very, very common case. And let's start directly with the case now. So this is a 1-year-old boy who's brought to you for your opinion, and parents are anxious as their 4-year-old nephew has been diagnosed with autism. And what they want to know is that, is their child okay? So this is where, because the prevalence is so high, you are going to get patients where, if one relative or some friend or somebody has been diagnosed with autism, and parents come all anxious with anxiety that is their child okay? So in this kind of a case, what should we be doing? And Shilpa has already talked a little bit about this, but developmental surveillance and developmental screening tests is something which we cannot go without anymore. So I think we need to start using this very, very regularly in our practice. And developmental screening tests are many. There are various international and various Indian screening tools, and I'm not going to talk about them today. But as Shilpa was talking, the developmental surveillance linked to immunization is what is the best way of surveilling a child. Now, this is something which I had started in Navi Mumbai and Raigad a few years ago, and in the last the webinar through the DIAP, it has actually gone fairly through the nation, and many pediatricians across the nation are using this chart. So as Shilpa mentioned, why with immunization? Because we are seeing the child 7 to 8 times in the first 2 years when the child is well and parents are not anxious. And the age is good for looking at development. Now, what does that mean? If we look at this kind of picture, where we are seeing the child at, say, 9 months, there are a lot of things which happen in the various skill areas at 9 months, which we can easily look at. So what I have done here is I have put the age, the vaccine, And what I want to do, you to do is not to put this developmental chart separately, but on the same immunization card as a new column. Because what happens is, at the same time when you're giving this, if there's a separate card, then that usually gets ignored. But if it's in the same immunization card, you can just look at it right there. And this is a chart which I think Shilpa was reading from, because at 9 months, what I have done here, for example, is 1 gross motor, 1 fine motor, 1 expressive, 1 play. So 1 point from each developmental skill area is what I have taken. And that's how the developmental surveillance, if you look at 18 months, the child should be walking unsupported and all these things. So with immunization, what happens is when you put it on the same chart, parents know what is expected and they can remind you if there's a deviation. Also, there's some documentation in case of regression, and it really takes a very few minutes extra. So we can start using this chart, and next time you make the your new files in the immunization on the immunization page, if you don't already have a developmental surveillance milestones, then please start using that. It's extremely helpful. So surveillance should be ideally of all children and certainly of high-risk children. And I've just enlisted some factors which are associated with increased prevalence of autism, some of which are associated with parents, like if there's a sibling with autism, there's advanced maternal paternal age, parental schizophrenia, use of sodium valproate, or there might be high risk associated with the child with various birth defects, chromosomal disorders, or neurogenetic syndromes. So in this case, when this nephew has been diagnosed with autism and this child has been brought to you with anxiety, this is what we need to do. We need to do a developmental surveillance, a screening test if you have, as Shilpa mentioned, OAE in all children. We need to be aware of the high risk group for autism and be also aware of the red flags of autism in the first 2 years. Okay, now let's go to the second case. And this is another very, very common case that you are going to see in your OPD. This is a 2-year-old boy who was born at 36 weeks gestation with a birth weight of 2.5 kilos with uneventful perinatal period. And what he has come to you is with concerns of upper respiratory infection or viral fever. And after you've sorted that out, while leaving, parents mentioned that this child is not speaking yet and he's only babbling. Now, what should be our response here? Because when the parent has come for an illness and just while leaving, parents are mentioning about their child's development, what they are looking at you is for reassurance. So it could well be the case that parents are not really worried about their child's speech, but they have asked their pediatrician. That is a demand for them, that they have talked to the pediatrician and pediatrician has said all is well. Or it could well be that one parent thinks, the mother thinks that the child has a concern, while the father is not concerned at all. To get their query sorted, they are mentioning this just while they are leaving your clinic. So usually, because it might be the busy OPD, or it could well be that you've already seen this child and the next child is waiting, the general tendency might be to reassure as well. And we might end up saying something like, oh yes, he looks okay, or boys speak late, or your elder son also spoke late. Or we might give some suggestions like, well, don't use too many languages, or he understands everything, so it's okay. Let's wait till 3 years of age. He's only 2 years. And maybe the parent might ask for it, or the tendency to prescribe something, a brain tonic, which might stimulate speech according to parents. And once we do this, because if we do this, then the parents are going to go back and think that all is well. And the next time the parents are going to worry about the child's development, maybe 6 months or 1 year later, and we might have lost a lot of time. So this is something which we should not be doing in any case. And why not? Because we not need to know whether it is only expressive speech delay or is there anything more. So here I have put the column as, this is speech, this is language, and this is communication. And most of us are quite aware about the difference between these three, but I'm just quickly going to run through this. What is speech? Speech is only the words which are coming out of our mouth. They may be meaningful, or they may be just repetitive or rote learned. Language is much more. Language means is associated with meaning. So language consists of understanding of what somebody is saying, that is receptive, processing it, and then expressing it using a set of grammar rules. And what is communication? Communication is a lot more. So language is verbal communication, while communication can be non-verbal or verbal. So we need to understand somebody's gestures or somebody's language and be able to communicate with them either through gestures or other methods or through language. So when the mother has talked about delayed speech, she's talking only about this part. What we need to find out whether all this is okay or not before we say all is well for them. And with the increasing prevalence of autism spectrum disorders, we have to ensure that we are not missing out on any early symptoms of ASD. Now, the reason I have underlined this early is because speech delay is actually not an early symptom. Because what is autism spectrum disorder? Autism spectrum disorder is a communication disorder. And so early symptoms can be easily missed because we cannot see it. And if we are not aware about what to look for, we will not be able to pick up the early signs. So course, I've just put down the core symptoms. We already know all this. It's impaired social communication and interaction and restricted and repetitive behavior. And this can be non-verbal, verbal, social relationships and all that. So when do the symptoms of autism spectrum disorder appear? The most common presenting symptom is speech delay. It's the one which we see or is presented to us in the OPD कि बच्चा बोलता नहीं है, and this usually happens between 2 to 3 years of age. This is the garden variety, the most common presenting symptom. However, autism is not a speech problem. It is a communication disorder, and communication is verbal and non-verbal. And speech is only verbal. So symptoms of non-verbal problems with communication must be present in the early developmental period, and we need to be aware about that. So what are those? Okay, so I've just put this here. I think Shilpa has already gone through it, but I'll quickly run through it. What is communication? It can be understanding of language or understanding of gestures. So just go through this. Communication can be understanding of gestures. What gestures? Bye-bye, pointing, facial expressions. What language? Before the first, within the first 2 years, he understands when the parent says no. He understands his name, names of various people, various body parts, and able to follow simple commands. And what about communicating in by expression? It can be non-verbal expression. So responsive smile, responsive facial expression, stretching the arms to be picked up, pointing, waving bye-bye by the child. All this the child is trying to express in a non-verbal way. And then verbal is our language, which starts with cooing, babbling, meaningful words, etc. So the early detection, we need to be aware about some of the red flags in the first 2 years of life, which can come before speech delay. And the first one, it could be this big smile, joyful expression that you see by 6 months or of age or so. And what is that? That's the social responsiveness and non-verbal expressive. The child is trying to express himself through non-verbal or non-verbal method. And that's right at around 6 months of age. Then as the child is older, at around 10 months of age, the child is not responding to his name. Now, what does that mean? It is understanding that this name is associated with me. So my name is Ayush. When they call me Ayush, this is for me, and to respond that starts by about 10 months. This is verbal comprehension milestone. Does not babble or coo by 12 months. It's verbal expressive. Does not gesture by 12 months. So this pointing, bye-bye, waving, show, all this is non-verbal expressive. Does not say single words by 16 months, verbal expressive. Does not say 2-word phrases by meaningful phrases by 24 months. And this is verbal expressive. So, and has any loss of language or social skill, that is regression. So these are the early symptoms of autism. However, all these symptoms may be quite subtle. And generally, it is easier for us to see them retrospectively than to see them when they're happening. But there are some early behaviors that we know are consistently present in autism spectrum disorder as compared to other developmental needs. And some of the, I've just mentioned three of them here. One is orientation to name. Second is meaningful eye contact. And third is joint attention. I'm just going to put some videos here. And this is which is showing how the joint attention, how the child is socially engaged. I'm going to allow the commentary from the video as well. Oh, sorry.
As he explores the new toy, he remains aware of the people nearby. He checks in with his mother behind him to ensure that she also sees the toy. Next, he shows that he understands the social communicative meaning of the woman's pointing gesture by immediately looking at the sticker. Then he looks over at another sticker she had pointed out before. He continues the woman's topic of communication as he points to the Tigger sticker. He shows the motivation to maintain social engagement with others and the ability to communicate using coordinated gaze, vocalization, and gesture.
So here he looked at what the lady was pointing at, and then he himself pointed at that. So there is this is joint attention. Next is, this is some play skills which we are looking at.
മോനെന്തേ അതുകൊണ്ട് മീൻ പിടിക്കാണോ കുഞ്ഞ് ചോറ് കഴിക്കാനാണോ? ശരി, എന്നാൽ മീൻ പിടിച്ചിട്ട് ചോറുണ്ടാക്കുവോ? ചോറുണ്ടാക്കിയിട്ട് അമ്മായിക്കതാ. നല്ല മീനാണല്ലോ. വലിയ മീനാണോ ചെറിയ മീനാണോ? വലിയ മീനാണോ ചെറിയ മീനാണോ?
So there is verbal, non-verbal expression.
വലിയ മീനാണോ ചെറിയ? എനിക്ക് തരുവാണോ?
Eye contact.
Pretend
play.
നന്നായിട്ടും ഉണ്ടാക്കിയല്ലോ മീൻ. ഒന്നുകൂടി പിടിക്കാൻ പോവാണോ?
And there is cooking some chicken for his mother.
എന്താ ചെയ്യണേ? ചിക്കൻ വെക്കാണോ? ചിക്കൻ ഉണ്ടാക്കാൻ പോവാണോ? ശരി. ചിക്കൻ ഉണ്ടാക്കി കഴിഞ്ഞു. ചിക്കൻ വെന്തോ?
And there is feeding the dolly. So beautiful pretend play there.
ചായ ഉണ്ടാക്കി കൊടുക്കാം. ഇന്നത്തോട്ട് ഒഴിച്ചോട്ടെ. ചായ ഇന്നത്തോട്ട് ഒഴിച്ചു.
The play. And the other one is imitating and doing some repetitive play.
നക്കിയാണോ കുടിക്കുന്നേ?
Okay, so this was a beautiful example where twins, when one twin is developing nicely in his social skills and the other one is quite behind with his slow social and play skills. Okay, so let's continue this case. This 2-year-old boy, the parents are asking about the child's speech just while leaving your clinic. What should be our response? So now that we know that we cannot leave this this child or leave this parent, and we can't give all those other points that we. Our response can be, we can try and find out all these aspects of communication, and we talked about this and ask parents about this, or we can do a screening test for autism. Now, ideally, the screening test for autism should be done in all children at 18 months and 24 months. And definitely, if there are concerns about a child's communication. We can do all this, or we can do a screening test for autism. Now, ideally, a screening test should be done in all children at 18 months and 24 months. And definitely, if there are concerns about communication. what does a screening test do? It helps to start a discussion with parents regarding the potential delays and disorders, because this parent is not aware, if the parent is not aware about the other areas of concern, these screening tests can pick up these concerns and make parents aware of the areas of concern. And thus parents can feel supported and empowered. What is the benefit for the child? See, early identification will facilitate treatment during a crucial and singular time in the child's life when intervention could have the greatest impact on brain development. What is the benefit for pediatrician? It is ethically required because disorder is already in progress, and if we can detect it early, effective treatments can be offered. And hence, as with all screening tests, if we are not doing screening tests and there is a disorder, there might be some medico-legal implications if we haven't picked them up. So, to screen or not to screen is not the question anymore. Screen we must. Which screening test? And there are many, but the one I'm going to just briefly touch upon is MCHAT follow-up. Why? Because it fulfills all the criteria of a good screening test. Now, we have been using it for a very, very long time. It's called Checklist for Autism in Toddlers, that's CHAT. And then it was modified in 2001 and called MCHAT. And the current version is MCHAT revised with follow-up, that is a 2009 one. What it has is, it is validated between 16 to 30 months of age. And what it does, it assesses the risk for autism spectrum disorders. It's a very quick test and it is freely downloadable. It is available in different languages and it is a 2-stage parent report screening tool. So this is where you give 20 questions to the parents and this is how it looks. I think this has been talked in detail various times, but I'm just going to quickly go through some of the questions which I find interesting. Now let us look at this. If you look at number 3, does your child play pretend or make believe? This is asking about the child's play pattern. Number 5, does your child make unusual finger movements near his eyes? This is asking about repetitive movements. Number 7, does your child point with one finger to show you something interesting? This is sharing of interest or initiation of joint attention. Does your child show you things? So all this, when you go through these 20 questions, it's going to, it raises those developmental milestones which we are talking about in autism spectrum disorders. But not a single question is about actual speech or expressive speech, which goes to, to confirm that autism is not about speech delay, it is about communication problem. And all these 20 questions help us to ask questions about all those non-verbal, verbal, expressive, receptive, play, etc., which usually we are unable to ask in a busy OP. So you do this MCHAT and a lot of things can be clear. Now, what I've done is I've written here, this 5 have come as no, which are concerning. So let's see, does your child show you things by bringing them to you or holding them up to see, but to share? So the child does not do that. If you turn your head to look at something, does your child look around to see what you're looking at? Then that's again no. So here, the response no indicates ASD risk, except in 2, 5, and 12 items. Now, what are 2, 5, and 12 items? If you look at 5 item, does your child make unusual finger movements? If you say yes, that's obviously a high risk for autism. A no is a normal, is not concerning. So it's very obvious. Sometimes we get confused between this, but when you look at the questions, the way they have been framed, it's quite obvious why a yes would indicate ASD risk. So if the score is 0 to 2, it's a low risk. So out of 20, you give scores, 0 to 2 will be low risk. And if the child is less than 2 years, you screen again after the second birthday. If it is 3 to 7, it's a medium risk and you do the next stage of parent questionnaire, that is a follow-up questionnaire. And if the score is 8 to 20, it is high risk. And then you bypass the follow-up and refer directly for assessments and early intervention. Follow-up screen, you'd select only those 4 or 5 items where the child has failed. And we don't need to do all the 20 questions again. And if the child fails any 2 items on the follow-up, then it is considered screen positive. So here again, if I'm just going to take one if I take number 7, does your child point with one finger? The follow-up question is like this, and it's very, very obvious. There are lots of examples here, how they are given, and it's a yes, no thing. So the parent can be asked in very simple terms to explain what they mean when they say yes or no to a question. So here, if we just asked about pointing with one finger to show something, the parent says yes, then you say, give me an example. And if he gives a past example, then that's fine. If he doesn't say, he says no, then you ask this question specifically because the parent may not have understood the question. So does the child ever want you to see something interesting like an aeroplane or a bug on the ground? And again, then no and yes goes on, and then you give pass or fail. So this is the way the follow-up questionnaire goes. And when you talk about positive MChat screen, if the follow-up out more than 2 are positive, then that's positive MChat screen. Now, what is this MChat screen is? It's a very sensitive scale, but not a very specific. What does that mean? It will pick up many cases of possible autism spectrum, but there's a high false positive rate. So which means that not all children who score at risk will be diagnosed finally with autism spectrum disorder. However, these children are at risk for other developmental disorders, and hence any MChat screen positive, further detailed evaluation is warranted who fails the screening. So this is something which we always have to remember, because many a times I've seen even professionals or psychologists writing MChat positive child diagnosed with autism spectrum. MChat is not a diagnostic test for autism spectrum. It is a screening test. For autism, we need to do further assessments. But when you get MChat positive, as we said, or there's almost a 50% chance that the child will have a diagnosis of autism, and more than 90% chance that the child has some form of developmental delay. So it is extremely worthwhile to spend those 5 minutes doing MChat with the parents. And even you don't have to do it. You can give it to your receptionist or assistant. It's once you train the assistant, it is a very straightforward questionnaire to do. Right. So we've done this. Now let's go to case 3. This 18-month-old has come for routine vaccinations and you notice some red flags. You do the ASD screening test, which is positive. What is the next step? So the screening test is positive. What are you going to tell the parents? That's the most important thing, because counseling at this stage will determine about which way the parent is going to go. What is the goal of screening? Any screening test, it is not going to prevent the disorder. The screening test in itself doesn't define quality or the benefit of treatment. It only creates an opportunity for early treatment. Now, after a screening test is positive, whether it's MChat or any, parents usually follow diverse paths. There are some parents who will be having full faith in you and will go into treatment quickly, while there will be some who will wait and watch, and there will be some who will go into complementary treatments, alternative medicines, even surgery, tongue-tie release operations, and whatnot. So the most important aspect of screening is actually not screening itself, but what happens after the screening. And ideally, what should happen? We should be referring, once the MChat screen is positive, you should be referring for hearing test, you should be referring for developmental evaluation, autism evaluation, and simultaneously parental education about evidence-based interventions and referral. Now, this is ideal. What happens practically? We all know that the resource services and expertise are not available easily. Secondly, parents don't understand the reason for diagnostic assessments. They want some treatment to make the child better quickly. Our cultural social belief system is that children develop, so just wait and watch. And in this, lot of time delay, cost in this diagnostic assessments, all this leads to a poor uptake of services. Or if they do take up some assessment somewhere, there might be compromise in quality of assessment. And this leads to poor quality of reports. Now, 50% and probably even more of screen positive who are referred for developmental assessments or autism assessments do not actually go through further assessment and are left and are lost to follow up. And in the meantime, the child suffers because alternative treatments are suggested by well-meaning but not well-informed relatives. So, do you have to do diagnostic assessment? Shall I wait for diagnosis? No, never, because MCHAT positive means 90% of them will have some developmental disorder and 50% will have, as we said, ASD diagnosis. So it is not the diagnosis or a diagnostic label, but it is the early intervention which is going to help change the developmental trajectory. Now, this early intervention, does it really work? And we really need to be convinced about this. And I think we all are, but I'm just going to go through a little bit, couple of slides on this, because this is what we are going to tell the parents. What are we going to understand from this? The prenatal and the first 3 years postnatal is single most transformative period in the entire lifespan for brain development. Because the neural circuits, they grow from simple to highly complex, the synapses double. And in the first, this happens in the first 2 years. And after that, pruning happens. And all this is dependent on input from the environment. So here it is, neurogenesis, new neurons forming, new synapses form. They all get strengthened by repetition and practicing an activity. And then the connections which are not used become weak. So neuroplasticity, what does it mean? Plasticity, it means that the brain is always learning, but it learns whatever is repeated. A young brain is not going to be able to understand whatever is given is good or bad, helpful or unhelpful. So whatever is given in the environment, the brain, and it's repeated constantly, is going to be learned by the brain. So what we are going to give, so this environmental input is utmost important in the first few years of a child's life. So if at-risk toddler is intervened before the brain circuit is established, there is best chance of developmental optimization. But if this child is neglected or not stimulated through environment, then we are going to have long-term issues with development. And this is what we are going to tell the parents, that if we lose this time frame for environmental stimulation, our child is going to suffer. And hence counseling parents regarding importance of prioritizing their child's environment, prioritizing the family parents' time during this crucial period is of utmost importance. All we need is one responsible, committed young adult to be involved heavily in the child. Now, when I say responsible and committed, lot of times both parents are working long hours. That's the need of the, that's the current need. And a lot of times there is either a maid, uneducated maid, or who's doing a lot of things at home and also looking at the child. So expecting her to have commitment towards optimizing the child's environment when she has 101 things to do is kind of expecting the wrong things from the maid. What about young adult? Again, joint family, grandparents, wonderful to have, but lot of times once parents go to work and they send grandparents with their child for therapies. Now, the amount of energy which is required to engage a young child is tremendous, and expecting grandparents to do that consistently is again wrong. So when we say responsible, committed young adult, one of the parents really needs to be involved heavily in the child. Another thing that we need to counsel the parents is, see, parents are focused on speech because that is what they can see. They are focused on this verbal communication. But these children on the autism spectrum disorder or at risk for autism have many pre-speech deficits, which we have to tackle before meaningful communication starts. What is pre-speech deficit? Our communication starts with with interaction. Then they'll play. That's what the whole communication starts with. Looking and listening and paying attention, language understanding. And then at the end, up here comes the speech sounds. Okay, so a blank referring to a speech therapist with the wrong expectation of parents and doctors of getting some speech out of the mouth is most certainly not early intervention, because early intervention needs to start here and not there. So if this is not happened, the rest of the things are not going to work. So it should be rank referring to a speech therapist for getting speech out of the mouth should be avoided. So what do you mean by early intervention, and what can we do? What can a pediatrician advise in the OPD to start as soon as possible for the parents? The first thing is talking about the screen time. And I think we all know about this. Again, just a couple of lines on this. Screen time is increased tremendously in toddlers. See, what happened was, suppose a child was born in 2020 or 2019. By the time the lockdown came, the child was an active toddler. To make him sit was a task for parents who were working from home. So then the screen time, so one thing leads to another, the screen time increased, and that caused a lot of issues as well. On top of that, if a child is genetically prone for autism spectrum disorder, then this decreased stimulation because of increasing screen time and decreasing the parent involvement with the child will cause a lot of problems. So discussing screen time is important. Let's start writing on our files, just like we say breast milk is is essential for the child's growth and brain development. Let's start writing screen time or mobiles are hazardous to the child's brain development. Okay, I think we need to start putting those in red on our files as well. So where should we start intervention? We should start here with interaction. What is interaction? Trying to get the child's eye contact, making dramatic facial expressions so that the child looks at you, making very huge gestures and drama in front of the child so the child starts focusing on the person, playing with the child. This joint attention, imitation, interactive play, this is all is what is needed. And this, the infant learns from the environment and on interactions that are rooted in social play, which occurs in our everyday caregiving activities. All these dedo lelo activities can be, is where the child is going to learn. And really most important is we have to stop teaching the children of 18 months and 2 years colors and ABCD, because as we said, what is repeated, so what the parents think when they are giving the screen time to the child is that they are putting the nursery rhymes and that's fine. So the child starts repeating the nursery rhymes and parent thinks that the speech is fine. But this is only rote repetition of nursery rhymes without any understanding. The child might start learning this, imitating this head, shoulders, knees, and toes, and parents think that the child is able to point to body parts. But when you ask them, the child is not able to do that. It is just a copying of what is happening on the mobile. So I think let's be very, these kind of things, when you start doing, all this will not need any detailed assessment or diagnostic labels. And when you start giving this simple advice, parents see change and are more amenable to long-term treatment. So some of the points to remember apart from all this is never, ever, ever, ever miss hearing impairment. And some other differentials or what we call as autism mimics is vision problem. Now I remember a child, this was many years back. He was a extreme prem baby and he was referred to me around 4 years of age for by the speech therapist, because the pediatrician had referred to speech therapist for speech delay. The speech therapist thought there was more than speech delay and concerned about autism spectrum, and she had referred to me. And to cut a long story short, this child had no vision in one eye and very little vision in another eye, secondary to retinopathy of prematurity. But this was again, so we need to be aware about all these mimics, this poor exposure, this emotional deprivation, and this has happened quite a bit. This neglect has happened quite a bit during the pandemic with both parents working from home. And I've had families who've told me that, when both the parents are working, they used to put the TV on and the child used to spend 4, 5, 6 hours in a locked, in a closed room in front of the TV. And then other developmental disorder, of course, we need to be aware about the genetic disorders, the Fragile X and all that. Okay. Another thing is, these are some of the charts, and this is in Navi Mumbai. We had distributed this on one of the autism in the days a few years back. And these are the early symptoms, that 6 months, 10 months, 12 months symptoms. And this can be put in the clinic, something like this can be put in the clinic room, where you are aware about this and you remember this, but even the parents can look at this. And if they see that their child is not responding when their name is called, they can ask your help for this. So what okay, so now this is happened that you have done an MChat, then you have talked about early intervention, screen time, and you have referred to a developmental pediatrician. What happens next? The child is back from developmental pediatrician. What is our role in the OPD about what happened with the developmental? So let's spend a few minutes discussing what the parents are talking about, what their experience was with the developmental pediatrician. Any reports talk about that. Reinforce the need for interventions and the home program. And by this time, parents will have done their Google search and will have many, many questions. So you need to be ready for some of the questions. One of the most common questions is vaccination and autism. And that is because usually it's around 15 to 18 months that these symptoms are being picked up. And there's a lot on Google about MMR, vaccine and autism. And we really need to be very clear in our idea that vaccination and autism, there is no evidence that it causes any autism spectrum disorder. And that message has to be conveyed to the parent. Now, children with the autism spectrum have loads of medical comorbidities. They have feeding problems. Because of that, they might be constipated. There are going to be sleep issues. And they are going to be in and out of your OPD for various, all these different problems. And you need to give priority appointments to this child. This family is already going to multiple places, multiple appointments, and so waiting in your clinic waiting area or reception area causes a lot of hassle for the family and other patients. Especially if the child is hyperactive, the parents really gets very stressed. So giving the first appointment or the last appointment of the day usually helps parent, and they feel really supported when you do that. Parents will discuss or will want to try out complementary medicine. They will want to try out homeopathy or Ayurvedic or many other those brain tonics that you get in the market. And you should be able to discuss this. And if you want, we can discuss it at the end. But we have to be very clear about reinforcing our advice regarding non-evidence-based, costly and potentially harmful treatment. So that we are not going to compromise. Sometimes some complementary medicines, we know that parents are going to try and we might support them through that. But there are some treatment modalities which might be potentially harmful, and we need to be very firm with parents about putting our advice across. Now, coming to this acceptance of diagnosis. Now, it's a roller coaster ride for parents. It's a process, because this is where it starts. As soon as you talk about autism spectrum, there is a huge shock to the parents. They do not think that their child has any problem. They will go into denial. And that kind of goes to the next stage, which is anger. They will be angry with either the primary care pediatrician or the developmental pediatrician or therapist, or they may be angry with themselves or with each other, because the mother might say, "Maine aapko bola tha kuch problem hai," and the father might have. So that anger, they just lash out at, they get very irritated, frustrated, till they read the next step, which is called bargaining. Here they start, reaching out to others, struggling to find meaning about what has happened to their child. And they might end up getting very overwhelmed and depressed before they go into this acceptance phase. So once they have gone into this acceptance phase, where they can start exploring real options to help their child. So as with any other chronic illness, even with autism spectrum disorder, there is this huge ups and downs that the parent goes through, with periods of active anger, passive depression, active acceptance, and we need to be able to support them through this cycle. Through this, again, within the family itself, there might be a parent who might be in denial, while the other might be depressed. The one might be anger, and other might be acceptance. There might be grandparents who will always be in denial or for a very, very long time, while the parents are trying to go through this phase. So supporting the parents through this, giving right information and communication during this phase, giving emotional support during bargaining phase, and then guidance and direction, the right direction during this acceptance phase. This goes a long way in supporting families and parents. I'm just going to quickly talk about this last case. Now, this 6-year-old with autism spectrum disorder, whom you had diagnosed or referred at 3 years of age, and the child has come back to you after a few years or months, and he has been on some therapies and a lot of complementary medications. The parents say he's very difficult to handle. He has a lot of self-injurious behavior. He's hyperactive, aggressive, sleep problems. So trying to sort this out is not easy. So we'll need to remember that when we refer for therapies, there has to be some kind of regulation that needs to happen. Now, there are many, many standalone therapy centers which operate on a closed door, in a closed door way, which means the therapist takes the child in, does some therapy, and gives the child back to the parent. Now, that is kind of one of the worst kind of things that, how is the parent going to know what is happening? So when we talk about therapies, they have to be one multidisciplinary. There are various therapy centers who kind of have started saying ki hum sab karte hain. So there might be an occupational therapist who will give parents speech therapy advice. There might be a speech therapist who might give special education advice. And I think what we need to, make the parents understand is, suppose you have a fracture. Will you go to a gynec for your fracture, or for your delivery, are you going to go to an orthopedic surgeon? How can an occupational therapy give you advice or a training on speech or special education? Let each one do their job. But all this has to be monitored by someone. So there has to be a central, either a pediatric neurologist or a developmental pediatrician, or you yourself, who is going to coordinate with the program or the therapist, or whatever the program the therapists are following. You are going to guide them, because when they come to a develop, we are going to set the goals for the therapist. We are going to see if the goals are going to be have been met or not. And if the goals have not been met, why are the goals not being met? Are the parents lacking in their home program? Are the therapists not doing the right kind of therapy? Or is the child's problem so severe that the child is not progressing? So all these therapies have to be not only multidisciplinary, evidence-based, but with definite family involvement and child-oriented. Another thing that we see very common is there is absolutely no documentation in a lot of therapy centers. I mean, I must say, therapists are, I'm going to put a disclaimer, therapists are wonderful. They are very, very hardworking professionals. But there are some where this documentation, where this closed door therapy keeps happening. And that is something which we need to be aware about, so that we can educate the parents about what a real therapy needs to be like. Documentation of goals, documentation of activities to be followed at home is a must, and regular follow-up is a must. Now, as we said, comorbidities are very common, and feeding, sleeping difficulties, if we do not tackle this early on, the rest of the intervention program is not going to work, because the mother is going to spend her entire day trying to feed this child who's a fussy eater, takes very long, and she has no time or energy to do any intervention program that we might suggest. So we really need to look at feeding difficulties, and the feeding difficulties in autism spectrum are because of various causes, sensory, oromotor, etc., etc. Sleeping problems are very common, and again, if we don't tackle this, the whole family is awake through the night, and it's going to affect the child's behavior the next day and the parents' involvement with the child next day. So we need to look at all this with the family. So a quick last slide: developmental surveillance screening in all and definitely in high risk cases. Let's be aware of red flags of ASD. We'll do autism screening at 18 and 24 months. It's extremely easy. Definite diagnosis not needed for intervention. Early intervention will change the child's developmental trajectory, and we see that day in and day out. And ongoing support from the primary care pediatrician is crucial for the family. Thank you very much.
Ma'am, it was a wonderful talk. It is always a pleasure to listen to your talks.
Thank you.
And you have covered almost all the concerns and questions that we had in our list.
Okay.
There are a few questions in the chat box.
Yeah.
I would like to go through those. Are DHA supplements effective in autism?
There's no evidence to show that it is effective in autism. Full stop. We can give it, but there is no evidence to show. There is no currently. It is a non-evidence based supplement. Whatever anybody else says.
Is there any pharmacological treatment for ASD with comorbidity?
Yes. So when we talk about drugs or medications in autism spectrum disorder, any behavior which is causing or any problem which is causing a problem with child's functioning has to be tackled. So there might be a child who has sleep problems. We might need to use melatonin supplements, or there might be a child with severe hyperactivity, which might need to use ADHD medications. We might need to use for extreme aggressiveness or irritability, something like risperidone, and for anxiety. So there are a certain pharmacological treatment that we can use for autism spectrum, but we really have to be very careful. Why are we starting them? Which symptoms are we trying to target? And we really need to follow up about how it is helping the child or not. What should be the endpoint? We need to be aware about what are the side effects of these medications, and we should definitely try and avoid polypharmacy, because that is what happens. We keep on adding drugs. I've seen a child on 5 medications and etc. And nobody knows what is happening with the child. So I think we need to be very cautious, but certainly in the right kind of children or right kind of scenario, there are medications which can help the child.
Any food avoidance can help in children's management?
Certainly, we say fizzy drinks, we say artificial colors, artificial flavors, caffeine containing products, because that can cause hyperactivity in a child. Then role of sugar, high sugar diet. Now, evidence doesn't say that whatever evidence is there does not show any correlation. But when we ask for anecdotal, there's definitely parents tell us the child, we cut down a bit, decrease the sugar in the diet, and the child seems to have calmed down to a certain extent. And decreasing the sugar is anyway a healthy habit, so there is no reason why we cannot promote that. Now, as far as this other food diets which are mentioned, like gluten-free or casein-free diet, where you try to avoid gluten-containing food or casein-containing milk products, unless there are some clinical symptoms which are suggestive of a gut problem, just shooting in the dark, andhere mein teer marne se matlab nahi hai. So I think GFCF as a evidence-based for all children with autism is not really something that we advise. In certain cases, yes, we can look into that. But again, under the guidance of a dietitian.
Is excessive crying at 8 to 9 months during vaccination visit a red flag for evaluation?
At 9 months, 8 to 9 months, excessive crying, depending on why the child is crying. So there are some children who may have low pain threshold and they cry excessively, or if we need to find out whether the crying is only because the child has come here, or how is the child's behavior the rest of it. Do your developmental surveillance, those points, and certainly if there is any concern, take it ahead.
Rajendra Chandrakar, sir, you have raised.
Yes, yeah, madam, I would want to ask one question. ADHD is this is an autism spectrum disease, or is it separate from autism? How do you differentiate ADHD from autism or autism spectrum disorders?
Correct. So autism spectrum disorder is one, ADHD is one. Okay,
Okay.
completely different core symptoms, but sometimes they overlap.
Right.
So you will have children on the autism spectrum with ADHD. You can have ADHD as a comorbidity.
Okay.
But if you want to differentiate between a pure ASD and a pure ADHD, in a
Okay.
child with ADHD, he can socially respond.
Okay.
He just waits for a minute. So if you are able to get the child to settle, you can see the social responsiveness very nicely. Or the
Okay.
child wants to the pretend play. All the other aspects are quite normal.
Right.
So I think in differentiating, a lot of times we I give a lot of importance to play of the child, whether
Okay.
there's imaginative play, whether there's pretend play, whether there's interactive play, because that is one of the things which is very either delayed or not present in children on the autism spectrum.
Okay. Okay. Yes. Thank you.
I have got one question.
Yes, sir.
If we find that child is not responding, or there is no stranger anxiety at the age of 6 months,
Yeah.
or no single words at the end of 1 year, should we wait till 18 months, or we should take action right now?
No, so we should never wait. When in doubt, we should start early intervention. Because what is early intervention? Early intervention is just playing with the child. It's stopping the TV time, stopping the mobile time, and giving parents what अगर आपने TV बंद किया, mobile बंद किया, तो करना क्या है बच्चे के साथ? Okay, that is early intervention, and that is rooted in some basic play skills of the child. So there is no harm in kind of giving those activities and then following the child up.
Thank you, madam. Thank you. And my another question is that how to differentiate between selective mutism and autism?
So in selective mutism, the child is perfectly fine, verbal, understanding everything at home or in familiar situations. But outside in strangers, they get into this childhood anxiety. It's called anxiety problem, and they go into they are mute. They are not talking in social situations. So in this, the only or the best way to differentiate is to ask the parents to get videos from home. Because you can see the child communicating beautifully at home, though he may not be able to communicate in your clinic.
Thank you. Thank you.
There's a question. Does IQ interfere with autism treatment?
IQ, sorry, interfere with?
Autism treatment.
IQ of the child.
IQ of the child.
IQ of the child. No, I think, yes, I think when we talk about prognosis, we say that low IQ has a worse prognosis than a child who has normal to average IQ. Now, let us talk about IQ for a few minutes, because I think that's it's a very interesting thing. When we talk about IQ, this IQ is intelligence is actually too complex to capture with a single number. Okay. Normally as well. It's an abstract concept, difficult to describe consistently. And we have different types of intelligence. Okay. Some can be measured, some cannot be measured. So when we talk about a child with autism, how do we get the child's, how do we determine this child's IQ? That is important, because it is not easy to test a child with autism for his IQ. Can you imagine if a child who has poor language skills, poor social skills, poor communication skills, wants sameness, wants routines, you take him to or he cannot tolerate bright lights, and you take him to a psychologist with brightly lit room and make him or ask him to do things which he can't understand, is he going to perform? So you're going to have a low IQ, even though the child might be okay in other areas. So difficulties of IQ testing in ASD is, we know that it is difficult to get an IQ test done, because our usual IQ tests look at verbal skills a lot. So we need specific IQ tests which look at non-verbal as well. So there are children who are very good at non-verbal. So I remember a study where what they had done was they had done IQ test with our usual Wechsler scale, which is done usually for all children. And they had done it with a Raven scale, which is only non-verbal. Okay, where you are allowed, the child is asked to copy patterns. What they found out was when they did with Wechslers and Ravens in a normally developing child, both the points came same. But in a child on the autism spectrum, there was a difference of almost 30 points. Now that is because a child who might come as intellectually disabled on a Wechsler scale was actually normal or above normal in a on the Raven scale. Now that is because what are we testing? That is what we are looking at. So if we are doing the test in the right way and we are getting a low IQ, then certainly it determines the severity of autism spectrum disorders and will affect the prognosis.
If a child is younger than 3 years and strongly suspected to have ASD, which therapies are to be started?
Now, that depends on where are the weaknesses. So it depends on whether the child has, so the child, we are saying that the child has ASD symptoms, which means the child's communication, non-verbal communication, understanding and expression, all are affected. Then the child's play is affected, and possibly the child's attention and arousal is affected. Now, what is attention and arousal? Arousal is being with the environment, what is happening in the environment and paying attention to the environment. Now, if that is affected and we start some other therapies, unless we correct this arousal or improve this arousal, how are other therapies going to work? So depending on where you are starting with, on that depends which therapy or therapies or intervention program is needed. So now what we are talking about is not individual therapies, but we talk about intervention programs. So in intervention program, you will have where a particular child's weaknesses are looked at, and then each point is worked on.
Ma'am, one more question. Genetics and autism are very related. So which are the genetic tests that we should insist on and which conditions usually? Is there some syndromes that we should be looking at? And if
no, so I think when we order genetic tests, we need to be very clear to parents why we are doing the genetic test. So one is parents usually want a recurrence risk if they're thinking of a second child. So, and we need to tell them that the recurrence risk is about, and it's not 2 to 5% more than the general population for the second set. Secondly, we need to educate them that the genetic tests we need to tell them because all these tests are expensive. So unless and until we have looking at a particular syndrome, just shooting in the dark sometimes doesn't give us much of clue. And we need to tell them that even if we get one particular clue, that's not going to change the child's treatment. So this has to be very clear to the parents before we barge on all the genetic tests. Now, if we are certainly looking at Fragile X, we are looking at if it's a girl with autism spectrum and thinking about Rett syndrome, we need to look for MECP2. But on an average, generally we look for chromosomal microarray and then take it step by step. And maybe we can ask for whole exome sequencing. But I think all this should be done with the help of a pediatric geneticist.
Madam, role of epigenetics?
A lot. Okay, and that's where the early intervention comes in. And that's what neuroplasticity is about. Because genetic load can be decreased or modified by the environmental stimulation.
And is there any role of consanguinity?
Sorry, of yes, yes. So there is, I think, a lot of syndromes are there which might have autism as this thing. So any genetic condition is higher in consanguinity, and so is autism spectrum.
Madam, as we see that the the milestones are regressed, particularly in language and others. Is there any outgrowings of these milestones? Or is it possible to outgrow these signs and symptoms?
Autism.
In autism after therapy?
No, so I think that's where it depends on the severity of, so it's a spectrum disorder. So it depends on where the child is lying on the spectrum. Now, if the child is, say, mild autism in a way where, which means what, the child is verbal, the child is able to communicate his needs, he may or may not be able to socially communicate. So there will be, even if the child progresses, some social behavior or some social communication deficits are usually can be seen. We might do standardized testing and the child might come out of the standard autism spectrum, the checklist, but he will still have some social communication, social behavioral issues, which might interfere with his daily living. So that's again, where we talk about, when you talk about autism, it is a mix of ability and disability. So they are very able in some and they are very disabled in some areas. So if we look at, when we look at IQ, we might have children who have normal or high IQ, but they are very poor in their daily skills. So only IQ is never effective to find out if the child is severe or not. We have to look at adaptive scales. So Vineland's adaptive scales, all those scales are essential to see whether the child is able to cope in daily life. So a child might have a high IQ but very low adaptive skills is not going to cope in daily life, while a child who might have lower IQ but better adaptive skills may be better outcome.
Thank you. Thank you.
So there are no more questions, ma'am, I think. Thank you for clearing all the questions and dilemma about dealing a child with autism. And I hope after today's session, we will be able to screen and counsel the parents better for an appropriate management.
Absolutely. The least we should be doing is MChat. वो तो नहीं करना हो ही नहीं सकता है. Okay. And hearing screen. I think we need to, OAE and MChat, I think need to be there in your checklist. Look at developmental surveillance, those charts, so that you're not missing out anything big. If you want those charts, you can just email it to me and I'll send it across along with a note on how to use them. When next time you make your files, make sure that you put that in your immunization card as an extra point.
Madam, our secretary will contact you for this chart. And
Sure.
then we will circulate in our
Sure.
all the members.
Certain.
Thank you, madam. Excellent lecture, very informative, very crispy.
Thank you. I think there was some problem with Zoom for in between.
Yeah,
so
yeah.
it got disconnected.
Yeah. We are sorry for that.
No. I think it is on my my part.
Achha,
Thank you so much. Yeah.
Hello.
Yeah.
Sir, something regarding medico-legal aspects of this issue. Dr. Ganguly. Hello.
Yeah.
Dr. Hemant.
Huh.
Dr. Hemant. I think it is not there. Madam, please, you please.
Hello.
My,
Wankhede sir.
हाँ
Mahesh.
Mahesh, बोल.
Achha, just for late onset autism, madam,
huh.
if you can. Something like if presenting other than the typical age, what we see, like
Yeah.
1.5 year.
Correct. So either it might be mild or it might be associated with some regression syndromes, which you might be able to tell us better, Mahesh.
Exactly. If someone is coming after 3-4 years
Yeah.
with the man, just last month I've seen a patient.
Yeah.
Referred by Dr. Gaikwad from Panvel. Patient presenting just stopped talking.
Yeah.
Start communicating and responses were delayed.
And of course, we need to worry about Landau-Kleffner and do the EEG. We know look at our regression milestones, regression workup.
I contact, he was like reluctant to answer. He gone gradually regression in the scholastic performance, and that came out to be ALD.
So ALD, childhood dysregulative disorders, Landau-Kleffner, all these, when the child is doing well and then suddenly starts regressing, all these other neurological problems we need to look at as well. Yes.
So I think anything which is other than the classical age of presentation, what the autism has, no? They
Absolutely.
speak 1.5 year, that's fine. Other than that, if any
Agreed.
additional feature you have, always see for secondary cause, I think.
Absolutely.
Nice one, madam.
Okay, wonderful. Thank you. So you were talking about the the medical legal is, I mean, what I am aware about is the Persons with Disability Act, which looks at inclusion in the schooling and has certain provisions for children or persons with disability. That's the act which is mainly used. There's a lot of information on the National Trust, the website about insurance, and we should always encourage parents to look at it.
Thank you, madam.
I think we can conclude the session.
Is there any insurance that covers therapies, madam?
The Star Insurance was saying that they have started, but I don't know for sure. Some private sectors are covering because they do take checks from me, the bills from me for therapies. Then this police force, the CRF, CPRF, they have, even if you do in private, they give 250 per session from their side. So whatever the cost, they have this upper limit of paying 250 per session. So there are some provisions which can be depending on the employer.
Main issue is regarding therapy, madam. It's
Absolutely.
cost.
Correct.
So many of them, they relapse.
Yes.
Just going, maybe lots of financial issue, other issues. Okay.
Any more questions? Shilpa?
So can we conclude the session then? Can I just
Yes.
No.
Yes.
Yes. Yes, Dr. Dhananjay.
I request Dr. Dhananjay sir to give the vote of thanks.
Yes. Thank you, ma'am. Thank you. We had a wonderful session today on autistic spectrum disorder. We are really fortunate to have Dr. Leena Dehspande, madam, a stalwart expert in the field of developmental pediatrics. On behalf of IIP Raigad, I would like to thank Dr. Leena, madam, for wonderful presentation and answering all the queries in detail. Sincere thanks to Dr. Shilpa, madam, for wonderful moderation. I would also like to thank Dr. Hemant Gangulia, sir, Maha IIP President, Dr. Pramod Wankhede, sir, IIP President, Dr. Dabhadkar, sir, Dr. Sasane, sir, Dr. Ranpise, sir, Dr. Jay Bhandarkar, sir, and Nilima Bhandarkar, madam, Dr. Neha, madam, Dr. Chitra Kulkarni, madam, and finally, thanks to Dr. Vishal Raut, sir, for making the Zoom platform available. And finally, sincere thanks to all the dignitaries who attended this session. Thank you. Thank you very much.
Thank you.
Thank you, madam.
Thanks. Bye. Good night.
Good night.